Thanks so much for allowing me to share the podium with such great speakers today. So what I'm going to take you to today is we're looking to really challenge conventional theories and thinkings around exercise in the elder adult. We're looking at sarcopenia, its definitions, its costs, how do we find the most at risk, and factors that worsen sarcopenia. I'm going to cover the basics of resistance training a little bit, and then Mary's going to look at resistance training specifically for osteoporosis. So sarcopenia, as Keelan said earlier, is a muscle disease rooted in adverse changes that accrue across a lifetime. So essentially what it is, it's a change in muscle quality and quantity that happen over life. And it's common amongst adults of older age, but can also occur in earlier life. So the healthcare costs associated with muscle weakness are quite significant. So this is a UK study and they've repeated it this year. So there's an average cost increase of £2,700 per sarcopenic patient in the NHS. And it's an estimated annual total cost of £2.5 billion. But what are the costs to the individual? Increased risk of functional impairment, reduced quality of life, physical frailty, and premature mortality. So when we look at the factors that really contribute to sarcopenia, as Professor Kennedy said earlier, and Keelan as well, we really do have changes in the quality and the quantity of our muscles. From about the age of 40, we're losing initial decline in strength caused by denervation in high threshold motor units. We have changes in anabolic resistance, so that initially that ability to produce power very quickly, or that maximal strength begins to change. This is compounded by, again, your inflammaging, having those chronic conditions alongside it, osteoarthritis, neurological disorders. But really the biggest thing is inactivity. 50% of sarcopenia, 50% of muscle loss can be attributed by just being inactive and not exercising. And then furthermore through malnutrition, so under intake of protein. So there's a working group in Europe called the European Working Group for Sarcopenia for the Elder Person. And what they have recommended is a pathway of how do we find people with sarcopenia in the community. So it starts with when they say signs and symptoms of sarcopenia, such as difficulty rising from a chair, falls, weight loss, or slow walking speed. So kind of really common things that you'd have in an ED or clinic, even with a younger population. What they recommend then is to do a SARC-F questionnaire, 5 simple questions just on their self-reported beliefs. So how much difficulty do you have carrying 10 pounds? How much difficulty do you have walking across a room, rising from a chair, climbing stairs, and how many falls have you had? And really a score of greater than or equal to 4 is indicative of sarcopenia and a poorer outcome overall. From there, from the self-report, you're looking at more your functional objective measures. So assessing muscle strength. They give the option of 2 different measures. It doesn't really matter which one you do, it's up to your clinical reasoning. So grip strength, and in men, the cutoff is 27 kilos, and in women, the cutoff is 16 kilos, or the 5 times sit to stand test. And when that's over 15 seconds, again, indicative of sarcopenia. From there, what they say is if someone is indicative of sarcopenia, you can start intervention, but best practice will be to confirm the amount of muscle quantity you have. So you've looked at the power, now you need to look at the quantity, and that can be done through DEXA or BIA, but they do say that in clinical practice, that's going to be unlikely that you're going to have these interventions to hand. So that you can go on and look at, is it really affecting their function now? So just through your simple functional tests, your time to go of greater than 20 seconds, and your SPB of less than 8, or a gait speed of 0.8 meters per second. So really what we need to think about is that these strength assessments are like red flags. They're going to show up functional limitations, increased need for healthcare support, ADLs and costs, and then the increased risk of mortality. So we really need to be thinking of our strength assessment as part of our overall comprehensive geriatric assessment. So a way to treat this, how do we manage it? So Keelan has presented kind of nutritional strategies we can use to manage this. The other option is progressive resistance training. What that is, it's a type of exercise where you exercise your muscles against some type of resistance that is progressively increased over time. So it's something that starts, it might be relatively easy, but it constantly gets harder, it constantly gets more challenging. And the evidence is really, really convincing for this. So it has impacts on health-related quality of life, improvements in muscle fiber size and lean body mass. And this paper actually said there's actually no non-responders to this type of exercise. No matter what comorbidity you have, you will get better with resistance exercise. And then the most recent Cochrane review by Sherrington et al. Found that when coupled with balanced training, it reduces falls in community dwelling adults by 34%. So again, not just from a sarcopenia point of view, from an overall health-related quality of life point of view, resistance training is a real center point of managing the elder adult. So that led to the International Clinical Practice Guidelines for Sarcopenia, giving it a strong recommendation for use in clinical practice. So how do we do it? Sounds lovely, doesn't it? How do we implement it in clinical practice? And that's where the real challenge actually comes through. And up until this year, we actually had very little guidance in the older, frailer adult, but the National Strength and Conditioning Association released these guidelines earlier last year. And very simply, they say 2 to 3 times a week, start at 20 to 30% of 1RM, which is your 1RM is what can you lift for 1 rep? What's the heaviest weight? And then you calculate backwards from there and progress to 80% of 1RM. Include power exercises at a lower intensity. So you're looking at progressive loading. It's constantly getting either heavier or harder in different movements, or you're looking at different speeds at which you're doing it. So maybe I'm going to get you to sit down slow, but stand up fast, making it a little, changing the differences of how the movement is performed. And then you're looking at multi-planar movements for falls prevention and educational functional approaches. So think about day-to-day lives, get them carrying objects, carrying bags. Mary likes to put weights in people's school bags and make them walk around all day long. So again, make it more cognitively challenging. But again, when we see it on paper like this, it's actually kind of hard to see how do you do it in practice, that carryover piece. So this is what it might look like for an older person. So first exercise here is a deadlift, picking stuff and up and down off the floor. Very functional, everybody needs to do it. So a 3x5 that's low reps, you're going to make it a more heavier exercise over time. Doesn't need to be a barbell. A barbell is probably the most straightforward way of doing it. You could use kettlebells, bags, loads of different functional ways. Then you've got a back squat there. Again, the weight is on the back. Mary will go through why they've chosen that exercise later. 4 by 6 to 7 reps. Bit more rep range. It's probably going to be slightly lighter. You might focus on the speed of it a little bit. Again, it's functional, standing up and sitting down against a load. And then adding in your more multi-planar single leg movements. So a lunge, can you lower yourself down on one leg? We also saw Operation Transformation last week where Dr. Niall Moyne was like, how do you tie your shoes? Well, this is going to train you for it. And then your balance exercises. So stand in tandem, perform an upright row, make it functional. And then a little bit more challenging, and I hate when I do this one, stand on one leg for 2 minutes. I want you to just build it up throughout the class. If it's little bits of 10 seconds, just get it in throughout the day. So for the older adult resistance training, these are really the key considerations that we need to do because adherence is such an issue. Plan programs that older people want to come to and continue. Make it fun, make it relatable. We all know we go to a class where there's someone funny and it's a bit of crack. That is the real heart of a good, consistent class. Emphasize the benefits of resistance training that older people identify for themselves. We don't like to call ourselves old, that these changes are happening. So don't call it, well, you're old and you're going to fall, so I'm going to say that. So, and be aware that many older people, they don't want to be categorized as such, and adapt the level and intensity of the program to the needs of the participants. Sometimes older people feel, particularly in gym-based programs, that they can't go there because everything is set at a certain level. Be adaptable, everything is scalable, everything is modifiable. It's just about the creativity that you use in your practice for it. So now we're going to, Mary's going to take over for me and talk about osteoporosis.
Thanks, Katie. Hi, everybody. Like sarcopenia, osteoporosis is more common as we get older. We lose bone as we get older. We also lose bone if we're less active. This trial, Lift More RCT, is the one I'm going to focus on. This is a trial that came out of Australia in 2017 by Belinda Beck's group. Belinda Beck is a physiotherapist with a research focus on bone density and exercise. Really, up until Lift More, what we had in terms of treating osteoporosis with exercise was focusing on balance retraining as a way of decreasing fractures related to falls. And we just didn't have the evidence that we could build bone with exercise. So quite frustrating in terms of what we could do with people with osteoporosis. The Lift More RCT is a welcome game changer in that regard. So exercise for bones, I mean, we know exercise is good for us, but when it comes to bone, not all exercise is equal. Non-specific exercise is just not effective for bone. Bone responds to intermittent high levels of strain, and only the bones directly loaded will respond. So that means that activities like walking and biceps curls are just not sufficiently targeted or intense to benefit clinically relevant sites like the spine and the hip. We need to do large multi-joint compound exercises like the squat and the deadlift like Katie had in her slides. These exercises apply large loads at the spine and the hip. High impact jumping is also really good for the hip, less effective for the spine. To date, really the issue with physios is we've been afraid that we're going to cause a fracture in a skeleton that we know is frail. So we've erred on the side of caution when it comes to exercise prescription, but not just an exercise prescription, also when it comes to exercise research. So the Lift More RCT is the first trial to really look at whether heavy lifting of any kind is safe in osteoporosis. So what did they do? They compared bone-targeted exercise, which they called high-intensity resistance and impact training, with a generic low-intensity home exercise program over a period of 8 months. There were 101 participants, all postmenopausal women, age range 60 to 70, all with low bone density, many of them with history of fragility fracture. And they measured height and BMI, DEXA scans pre and post, lower limb and back extensor muscle strength, and they did functional measures, timed up and go, 5 times sit to stand, functional reach test, maximal vertical jump test. So all the things we know are important if we're wanting to make sure someone isn't going to fall. Then, as you can see there, both groups exercised twice a week. The intervention group were supervised while they exercised. Both groups just did 30 minutes, so manageable twice a week. The intervention group focused on barbell exercises like we were talking about, back squat, deadlift, overhead press. They also did jumping chin-ups and drop landings for the impact portion. They started off learning the exercises using body weight and low load variants and progressed to 5 sets of 5 repetitions at 80 to 85% of their 1 repetition maximum. So that's quite heavy lifting. The physios in the audience will be aware of what that means. So we're talking heavy loads. The control group, the home exercise group, they did a generic strength program. They did use resistance. They used 3 kilogram dumbbells, but quite a lot less work than the intervention group. So when the study came out, when they were looking at their interim results, the researchers got quite excited because the midway figures were really good, way better than they had expected, and they got quite a lot of media attention. And this is just a clip from Australian News showing participants in action, so it's nice just to get a flavour of what it's like.
These women are working out to beat brittle bones. It's a new way to prevent crippling osteoporosis, high-intensity weight training instead of low impact.
When you're older and you have osteoporosis, those kinds of exercises were always thought to be dangerous.
But the 8-month study by Griffith University has found the opposite.
Since I don't fall.
These women, all over 60, have built up bone mass and recorded less falls.
I had no strength whatsoever.
Now Robin Anderson is deadlifting
Between 50 and 55.
almost her body weight. Sue Solder's personal best is 72 kilos.
Yes. We've had amazing results compared to the results that you typically see in the literature.
We do have some women who have fallen over, but they haven't broken a bone.
Because they are stronger.
Coming here, I've built up my spine 8%. They tell me that my back is straightening up.
There are 6 million osteoporosis sufferers in Australia. Between them, they get a fracture every 3 minutes. The Bone Clinics program is scientifically designed and involves just 2 sessions a week.
I go home and I say I left for 32 Ks today, and he's just amazed.
It's great to see them in action, isn't it? So the results were really good. Improvements were observed in every outcome measure in the high intensity resistance impact training group. Huge improvements in lumbar spine and femoral neck bone mineral density of the kind not seen previously in the exercise literature in osteoporosis. Big improvements in back extensor and lower extremity strength. Physical performance measures all improved, which meant that these people were at decreased risk of falling and fracture. There were no injuries sustained during Lift More. And the researchers they highlighted the fact that they introduced these movements gradually, and there was close ongoing supervision while they exercised with a focus on correct technique, that this was key to the safety part of this. So they proved that really women with marked osteoporosis and previous history of fracture could tolerate a heavy lifting and impact program safely, and they could build more bone than previously reported with exercise interventions. They also, their spines were straightening up, as that lady said. So you can see from left to right there, quite a different look in the spine. And same with these ladies, quite marked. And they didn't expect that to happen. So I think it's safe to say that exercise is a double whammy when compared to medications. Targeted exercise both prevents falls and fractures, as well as increasing bone density, and there are no adverse effects. However, there are some issues when it comes to translating this approach to real-life exercise implementation. It does require supervision by well-trained exercise specialists. This might make it impractical for community rollout. And it's not suitable for everyone. There's an affordability issue, there's an adherence issue, because it is quite hard work. You saw those ladies working away quite hard, not to everyone's liking. We don't know if people with comorbidities like significant osteoarthritis of the hip or the knee would be able to tolerate it. Also, people with cardiovascular respiratory issues might not be able to tolerate it. In Australia, they're getting over the affordability question by looking for government reimbursement for evidence-based exercise therapy, which is something we could look at, I suppose, in this country as well. Findings of the Lift More approach have been implemented in Australia in novel translational research clinics, the Bone Clinic, of which there are 8 in Australia. At the Bone Clinic, men and women of all ages with low bone density come and exercise twice a week doing the Lift More program, where they're supervised. And they comprise a study sample where they're continuing to complete they're checking their DEXA scans and complete their measures all the time. And they've shown even better outcomes than those seen in the trial. And the reasoning being behind that these people have been exercising and following this program for more than 3 years now, a lot longer than the 8-month trial period. O'Neill Online is an online program given by the same group that targets strength, impact loading, mobility and balance. It isn't the same as the Lift More program because it focuses on exercise that can be done safely at home. They're not seeing the same kind of results with that type of approach. When Lift More came out in 2017, it was initially accepted cautiously as a driver of change in exercise prescription for osteoporosis. People were still quite worried about loading up fragile skeletons, and this was just one trial with 100 participants. Since Lift More, though, research has been focusing on this approach, and evidence has been building for the benefits of PRT in this cohort. So these trials completed in 2019 continue to add to the evidence, and there's ongoing research that's worth looking out for to see if that continues to add to the evidence for this approach. And just to finish on this, I suppose, call to action really, Professor Daly is another renowned bone health researcher, and this statement by him, targeted and progressive research is the only approach that can improve all the risk factors in osteoporosis. So that's saying it all really. We need to start getting people into exercise young and making it easy for them to continue into old age, make it attractive for them to continue into old age, as Katie said. So we need to, get on to policymakers so that programs can be rolled out at community level and that they're affordable and easy to access. Exercise is good for all sorts of chronic conditions, heart disease, obesity, diabetes, depression, dementia. The list is endless really, it goes on and on. So it really is a no-brainer. We need real investment in physical activity and exercise as part of any preventative health strategy. So that's the end. Thank you very much.